Welcome, everybody, to Cancer Prevention and Wellness. We'll get started in just a couple minutes. So good evening. I hope everybody's had a great Thursday. This is Dr. Jeff Jagir, and I am your host for Cancer Survivors Park Alliance presentation of cancer prevention and wellness. Every month, we cover a topic to include a specific organ system and cancers associated with that, or a healing modality, or some kind of screening prevention technique. The goal is to give you knowledge, and we feel like knowledge is power, and it's the power to hopefully help you get healthy again and or keep you healthy if you're having no issues right now. This time of 5:30 on a Thursday evening isn't convenient for everybody. We therefore record these Zoom sessions, and this recording will be available via the Cancer Survivors Park website, and that's cancersurvivorspark.org. If you like what you see, there's an entire library of, we've been doing this for many years now, and there's probably 4 years of different topics that we've covered that you can look through and see if there's a recording that would be particularly helpful to you. We'll try to make that site available to you and easy to access with minimal clicks via our website. A couple of organizational kind of housekeeping things. The audience will be muted. We do not want to discourage questions. I will be monitoring any questions via the chat feature. We may have some references that will also be up via chat that you can refer to via click. And again, all this will be recorded and available to you in a couple of days on our website. So tonight, we're going to discuss all things about the colon, ideas worth ingesting, everything you wanted to know about the colon. We are pleased to have Dr. Anjani Jamula. Dr. Jamula was trained and going forward in an OBGYN tract, and then moved west and decided on a different tract for her medical career, and trained within the Cornell system in a residency, did chief residency, and then did a nutrition fellowship, as well as a gastroenterology fellowship at Memorial Sloan Kettering Cancer Center, a really famous cancer center in New York City. But we're happy that she's moved to the upstate and is the fellowship director for GI fellowships at Prisma Health. So Dr. Jamula, I will hand that over to you now.
Thank you, Dr. Jagir. That was very kind of you. That's a nice introduction. Thank you, everyone, for being here. I'd like to thank the organizers for giving me the opportunity. So today, with that love for cancer prevention and my prior training at the Cancer Institute, as Dr. Jagir mentioned, very early on after I moved to Greenville in 2013, I became an integral part of the Cancer Center here, and has been working with the survivorship clinic with all the advanced practice providers, and used to work with Dr. Gluck, taking care of patients in terms of mostly preventive care. Any gastrointestinal cancer, colon, stomach, pancreatic, some families where there are genetic mutations that the mutation has been passed upon. So I have tremendous love for my patients that come from cancer centers. With that introduction, I would like to move forward and talk more about what can I educate about anyone about what do I do in my daily life. It's everything that I learned so far about colon, also known as large intestine. So a few facts about your large intestine. It's a muscular tube of about 150 centimeters in length. And the main function of it is truly water absorption. And it can take up to, after we ingest anything through our mouth, it doesn't turn into stool in a very short period. It can take up to 1 to 3 days, depending upon the person. And there are certain regions how we label this colon. As you can see, it's very descriptive. It starts at the junction between your small intestine and the large intestine. That's where your appendix comes out of it. The appendix truly does not have any function in our body, but all of this is colon. When it goes up, we call it as ascending colon. And when the region that actually lies down in the middle, we call it as transverse colon. And that portion of the colon where it's actually coming down from top to bottom, we call it as descending colon. So far it's easy. It's ascending, transverse, descending. And the fourth part, we call it as sigmoid colon because it's like an S shape, the siphon shaped. And the last part is called as rectum. And the rectum is truly, a receptacle. That's how I would describe it as. It's like a sac-like thing. The job of the rectum is truly wait until a certain amount of waste material comes into it, and then send nerve signals to your brain and tell the brain, hey, listen, I'm ready. You need to use the bathroom. That's usually the job of your rectum. And then that's connected to the exterior through anus. So that is your normal anatomy and physiology of the colon. All right. So I'm sure some of you have visualized this in a gastroenterologist chart or online. I have in all of my cabinets in my rooms, and I do use these cards showing this to my patients. This is, as much as it's not aesthetic, but it is very, very helpful to understand what the patient is going through when they come to our office reporting some symptoms. So as you can see, it goes from type 1 to type 7. Anything between type 4 is your ideal, but anything between type 3 to type 5 is manageable. And any numbers above and beyond the spectrum are abnormal, and we try to help patients by giving them advice in terms of diet or in terms of medications to bring them back to an ideal type 4. This is called Bristol stool chart. So now, as a gastroenterologist who handle any areas throughout the gastrointestinal tract, including your esophagus and stomach, that's the sequence: your food pipe, your stomach, your small intestine, and then your large intestine. The beauty of GI is every area in this system has its own unique pathology, meaning unique diseases. So the large intestine is not an exception to that uniqueness. What you see in the large intestine, you will not see in the small intestine, and you will not see them in the stomach. That's what I meant when they're unique. So the common words, I have put some boxes here that you may have heard either from your friends or family, or, when you went to the doctor and yourself. Diverticulosis, which is a pretty common condition where these blebs or outpouchings that can form in the colon. Typically, they are more commonly seen in the sigmoid colon or the descending colon, where it's coming down, and they're pretty indolent. Sometimes they could lead to bleeding if there is excessive constipation and straining, but we may not know the full reason why somebody can bleed from them, and that diverticular bleeding is not easy to handle, meaning it's a lot of bleeding. It will stop on its own, but it's a lot of bleeding that it makes someone panic, and they need to be in the ER. And these diverticula can also at times get inflamed. And when they get inflamed, they lead to abdominal pain, fever, chills, nausea, vomiting, and also a lot of pain. And they need to be, again, sometimes need a CT scan to diagnose it. And we treat them with antibiotics and taking it easy with diet. And it takes a few days to cool that off. In a very rare circumstance, it can also lead to a complicated diverticulitis where it can lead to a hole in the colon or major perforation that we call it as requiring emergency surgery. So that is related to the diverticulitis and diverticulosis. Now, there could be infections that we all have heard of. It could be bacterial, could be viral infections. A lot of times they are either self-limited, meaning they get better by themselves, or you need a set of antibiotics to get better. That's your infection in the colon. And these two, the words ulcerative colitis and Crohn's disease, are also very unique to the large intestine. Ulcerative colitis is exclusively limited to the large intestine, and Crohn's you can see anywhere throughout the GI tract. But these two are inflammatory conditions, meaning there is no cure to them, but there is treatment to them. And they are sort of cousins. They're not the same, but they act like cousins in terms of their properties, in terms of the symptoms, in terms of how do we treat them, the age of onset. That's a complete different umbrella. So that's a pathology that is also not uncommon for a gastroenterologist to see. And the more important ones, the crux of our topic today, is colon cancer and colon polyps. So polyps, as you see here, I have pictures later on during my talk. They can come in various sizes and shapes, and they can be at any location throughout the large intestine. And the cancer also can happen at anywhere throughout the large intestine. Those are the common things that we take care of pertinent to the colon. All right, now moving on to the colorectal cancer. From here on, I will address CRC, that's colorectal cancer. And by definition, it can start anywhere in the colon or rectum. So 5 feet muscular tube, it can start anywhere in the beginning or at the end or anything in between, all of them called as together as colorectal cancer. You can call it as colon cancer if it's not coming from the rectum, just to differentiate from the site of origin, if it's coming from rectum based on where it starts. But for a lot of practical purposes, we group them together as they both may have common features with some differences. And we'll go into what those differences are. So colon cancer, if you look at it, it's equally common in both genders. You don't use radiation commonly to treat this, and the surgical treatment is relatively easy, whereas rectal cancer is more common in men. It could metastasize easily, metastasize meaning spreading beyond the colon, and it's a little more difficult to cure. And the common, in this Venn diagram, the common features are the risk factors are pretty similar. What actually predisposes to both of them is the same. The symptoms could be similar, and the incidence rates, which means how many new number of these cancers are diagnosed every year, also they follow a parallel graph. And the genetic makeup, meaning if someone has a mutation that is passed upon from one generation to the other, those mutations are similar in either one of them. Just to get into some numbers, how big is this problem in our country? 1 in 26 women and 1 in 23 men in their lifetime will develop colorectal cancer. So as you see, it's a little more common in men. And in the US, currently, it is the fourth most common cancer among others that's being diagnosed. It's also the second leading cause of cancer-related death in the United States. So again, this is the 2024 estimation that if you see breast cancer is in the order of 300,000, more than 300,000, prostate is around also 300,000, lung cancer about 230, colorectal is about 153,000. This is the estimated number. And if you go back and look at in the last 5 to 10 years, these numbers have relatively lurking around the same statistic.
Dr. Jamula, from the standpoint of presentation, if you could just move a little to your right, when you go to your left, when we lose you sound wise.
Oh, is it better now?
Yeah, very good.
Okay, all right. Sorry about that.
No problem.
Now, estimated cancer-related deaths, when you specify by the type of cancer, lung cancer is the killer, as you can see. Colorectal cancer is about 53,000. So about 1/3 of them, like 153,000 diagnosed, 53,000 is our mortality per year. So this is the hot topic these days. What is the age group? What is the population that we are targeting in terms of, preventing this colon cancer effectively? So 1969 is when truly the colonoscopy came into effect. It was done at Beth Israel Medical Center in New York. And then essentially in the 70s is where we picked it up and then started making this a routine for, the average American for more than 50 years of age to start screening. So once the screening protocols were put in place, as you can see, the incidence rates in all ages have been dropping from 1975 to 2020. It went from about 60 people in 100,000 to 33 per 100,000. So pretty much halved over this duration, over these years. And we do think that it's from widespread screening among adults more than 50, and also our treatment options also have become significantly better, more accessible over those decades. So those two factors essentially played a role. But then when you broke down those numbers by age group, since the mid-1990s, we have seen a startling increase in the incidence of this younger population, meaning whoever is less than 50, every year we kept seeing an increase in the incidence by 2% per year. And I have a few slides later on, we discuss about it as we move forward. But that's the population that we are trying to find out why it's happening. We still don't know yet, but that's the population that's at an alarming rise right now. Now, mortality, which means death in all ages, also dropped by 57% from 1970 to 2020. Again, went from 29 people per 100,000 to about 13 per 100,000. Again, we attributed that to better screening, improvements in treatment, so all of those. Again, when you look at the mortality rates or the death rates in the relatively younger population, the mortality rate was also on the rise. Now, again, this is a graph to depict how the incidence over the course of years have been coming down. This is all ages, not the younger population, but it's nicely downtrending.
It's been we've highlighted, if you can go back, the fact that so many cancers, the incidence is going up. And it seems to be that because you're dealing with polyps, early on, that maybe the incidence of colon cancer is declining. We're doing better once we find a cancer and treating it, and mortality is going down for a lot of cancers. But, our whole goal with this kind of prevention kind of approach and lifestyle type approach, which I know you're going to get to in detail, is to kind of start working on the incidence of cancer ever happening, not just, having a reactive medical aspect of treatment that is toxic and expensive. So
true. Prevention is the key here.
Trying to be proactive, yes.
All right. So, over the course of years, we have identified some risk factors. Like, what are those risk factors? And some of them are in our hands, some of them are not in our hands. So those we can change, the alcohol consumption, the tobacco use, the sedentary lifestyle, diet rich in red meat, low fiber and vegetable intake. So those are all the things, those are modifiable risk factors, we call them as. And some of them you can change, wish we could, aging. And then the prior history of polyps or a prior history of colon cancer, or your family history of, advanced colon polyps, or a family history of colon cancer, prior exposure to radiation, like someone who has had some other cancer for which they received radiation by its toxicity puts you at a higher risk for developing polyps and subsequently cancer. And then the inherited colorectal cancer syndromes, that's another whole separate topic to discuss, where an abnormal gene is passed on across the generations, where, again, every gene has its own specific way it transmits from, parents to the children, and it can skip generations. So there is a way that we can test for it, and our cancer center has an extremely strong genetics program who do a phenomenal job, all the counselors there. And the other non-modifiable risk factor is your inflammatory bowel disease, which I touched upon earlier during the pathology. Patients who have had ulcerative colitis or Crohn's disease involving the colon that was diagnosed when they were younger in their 20s or 30s, after a certain number of years, they are at a higher risk for developing colon cancer. And the reason it happens is any chronic inflammation in your body, and this holds true for a lot of organs, any place where the inflammation has been active for many, many years, that can lead to, we call it as dysplasia, which means precancerous cells, and that dysplasia can lead to cancer. So we have protocols that we develop to screen these individuals appropriately and then identify any precancerous cells at an earlier phase so as to prevent them from developing the cancer in future. And what are the signs and symptoms of colon cancer? Like, say I have someone that walked into my office today and told me, listen, doc, I have seen blood in my stool in the last 3 months. And I also think that my appetite has been going down, and I think I lost about 30 pounds. That rings a bell in my brain, and I have to be ready to scope that person the same week. So those are the really alarming signs or symptoms that the patient just told you. But there could be some subtle symptoms that they, may or may not be able to pick them up right away. But here are the things that patients or the population need to be aware of. Any change in your bowel habits, like say some people, it's like a clock. I drink my cup of coffee in the morning and then 4 minutes later, I'm in the bathroom. For that person, if he's struggling to have a bowel movement and he's not moving his bowels at least once, not even once every 2 or 3 days, that's a change for him. And that should raise in an alarm as to why is this happening? What is happening? Same thing with the diarrhea, who were always a Bristol 4 and nice stool, and now they have loose stool. So that's also something that we need to worry about. And a change in the stool caliber. What that means is the size of the stool, the diameter becomes smaller, become pencil thin stools. Again, that happens because the tumor constricts and decreases the size of the colonic lumen from it being this large to like smaller. So your stool gets compressed, and by the time it's exited, the caliber is smaller. Bleeding, cancer tends to have bleeding because it has new blood vessels all over the place. And those blood vessels are not strongly supported, so they tend to start opening up and then they start bleeding. And then the reason I put both of those there are rectal bleeding and blood in the stool. And blood in the stool is something that it's like sometimes patients tell you that, oh, there is bright red blood, it's coating my stool, it's on the surface. 9 out of 10 times it's hemorrhoids. But then again, do I ignore saying that it's a hemorrhoid? I cannot, because a large colon polyp or cancer in the rectum can also present in such a way. So regardless of the age, when someone walks into my office complaining of, especially if it's a new symptom for them, I will offer them a colonoscopy to assess.
No matter what their age.
Yeah, I mean, in this, especially the young onset, even in their 20s, I do offer them a colonoscopy. Unless they're severely constipated and they want to hold off and treat the constipation better, come back in 3 months. I'm not just saying that, I'm not reassuring them that this is fine, go, I will bring them back, keep an eye on them, check the labs and things like that.
I think we have to get the word out to the younger folks that, these kind of signs and symptoms, if they happen to you, you just can't put them off as not something significant.
Exactly. Those are the two challenges in the young onset colon cancer, where diagnosing them and then how do we dealing with the diagnosis itself. It's just is a very tough thing for them because they feel alone in the sense that like whoever is more than 50, 60, we have at least heard about a colonoscopy. We have heard about a friend or a family member or someone being diagnosed with colon cancer. It's not as a shocker as much as it is for a 20, 30-year-old when you give the diagnosis. It's just is very obvious when we deal with these two separate age groups. And then abdominal discomfort or weight a vague new onset abdominal pain, if they're feeling fatigued or weakness, they're getting weight loss, we talked about it. And this last sentence that I have is, we call it as rectal tenesmus in medical literature. What it is the patient experiences a sensation that they have to go to the bathroom, they go sit on the toilet and nothing happens. And they come out an hour later, the same feeling, they have to go back again. And the reason it happens is because the nerve endings in the rectum are very sensitive. So if you have, it can be an inflammation, it can be polyp, it can be cancer. When that gets irritated, patients have that sensation, oh, I have to go empty, but then there is nothing to empty. So that is also a symptom that we have to pay attention when they tell us. So how do we diagnose colon cancer? Like say, as I said, I had this gentleman who I have seen in the office, and I essentially suspecting it, right? So first I start with a physical exam and including a rectal exam here. I can't reinforce how important that is, especially when they come in with a symptom of blood in the stool. Of course, with your digital exam, you're not going much further, but if you feel a mass on your digital exam, that's no-brainer that's the mass that was bleeding all this time. Blood tests to identify if their blood counts are low, do they need blood transfusion, do they need iron studies, and then a stool test to detect blood in the stool. We call it as a Guaiac test, where you could use a card and test for the blood cells, and then the next step is your colonoscopy, which we'll go over. Say that I performed a colonoscopy and I found a mass. And what do I do with that? I biopsy and then send it to pathology. I request the pathologist to get me the answer quickly if they can. And if that is confirmed, then I pick up the phone and I call one of my surgeons. Along with that, I also send the patient for a CT scan. The reason I send them for a CT scan is to identify whether this tumor is still contained within the colon or it has spread outside the colon. And the most common other solid organ that the colon cancer goes to is liver. It can go anywhere, but certainly liver is the more common area. The reason being the blood supply from all the intestines is drained quickly into the liver, and that's when the cells also go large in the liver to develop lesions or metastases, we call it as. Along with the CT scan, I also order blood tests for tumor markers. We call it as CEA. And sometimes we order a PET scan and then an endoscopic ultrasound if it is a mass in the rectum. Everywhere else, you do not need an endoscopic ultrasound, but then for rectal tumor, if it's subtle, small, to stage what layers of the rectum are involved, we do that study. All right, now. So this is purely staging of colon cancer and what that translates into in the form of survival rates. So if you look at it, stage 1 colon cancer, which is very restricted to the lining of the colon, the survival rate is more than 95%. So this is where the screening and early detection. Screening is identifying before it turns into cancer. Early detection is identifying at a very early stage. So if you look at the numbers, stage 1 colon cancer has a survival rate of 95%, which is tremendous. And stage 2 survival rate is 70%. And if you go to stage 3, that's about 50%, and stage 4 is less than 5%. So once you notice this huge difference in the survival rate, you want this to be diagnosed at an early stage and be cured of it. And
you get the impression that stage 1, 2, 3, they get bigger, and that's probably true. But the real difference between stage 1 and stage 3 is how many layers of the intestine they've invaded.
Yes, and the lymph nodes and how many layers it has gone through. So. All right, and now. So as I mentioned earlier that I'll pick up a phone and call colorectal surgeon. So who is involved in treating once you get diagnosed with colon cancer? It's truly a multidisciplinary approach. There are so many of us, not necessarily just doctors, but ancillary team. So you work with a gastroenterologist who essentially diagnosed you, and then a surgical oncologist who uses surgery to treat cancer, a colorectal surgeon who performs surgery on the colon and rectum. a radiation oncologist who treats cancer with radiation therapy. And we mentioned earlier that rectal cancer sometimes uses radiation. And a medical oncologist like Dr. Jagir, who treats cancer with chemotherapy or targeted therapy. And along with all of these specialists, you're going to be under the care of, like, say someone needed an ostomy or a bag, an ostomy nurse is important. And then there are several nurses and nurse navigators and chemotherapy centers, infusion center nurses. So you are going to be taken care of by multiple disciplines. And that's how the therapy is very successful when you have all of us working together. And in fact, Prisma actually has, the Cancer Center arranges a multidisciplinary GI cancer conference every Friday, and we discuss patients that are going to be seen that day. There are going to be every one of us, a GI doctor, surgeons, the pathologist, the radiologist, all the oncologists come together and we discuss and we come up with a comprehensive, careful plan and the best plan for that particular patient and for that particular stage of cancer. So now, say you diagnose, these are questions that we touched upon earlier already, but where is the cancer located, meaning what part of the colon? Did it spread beyond anywhere? What is the stage and what does that mean to me? Will I need any other tests before we can decide on treatment? And definitely this is a shared decision where you get to talk to about, what surgery, what are the side effects of the surgery? How do I deal with this? How long is the treatment? Where will this treatment be done? Can it be done closer to home? Like say you live in Spartanburg, can I get this therapy closer to home instead of driving 30 miles? So, these are all the logistical questions. What are the risks of therapy? How will this affect my daily activities? Like say, for example, someone is an avid swimmer and that's their lifestyle and exercise and all of that. And now, unfortunately they have a bag and it's that affects their lifestyle. So these are all the adjustments that, a person have to make based upon how the treatment will affect them. What are my chances that this cancer will come back? What will we do if the treatment does not work or if the cancer recurs? In the sense that what is my plan B? Do you have a second option for me if the first line actually fails? Now, how do we treat this? Early stage colon cancers, we do tend to remove the malignant polyp, which means that if the polyp is large enough, but if the cells are very much contained within the polyp, it could be removed during a colonoscopy. And the pathologist will tell us whether the margins of the polyp that were removed are completely free. And if they are free, that is the only treatment at that time that's needed. And we just have to follow that person. And depending on the stage, again, local excision, which means removing it, just a portion of it and not necessarily a colon. And hemicolectomy, which means a part of your colon is removed. And that could be done laparoscopically, robotic assisted, or an open surgery. And this is done by either a surgical oncologist or a colorectal surgeon. And sometimes the tumor is so big that it actually blocks the entire lumen of the colon and the person is suffering from constipation, unable to pass gas. And we do offer placement of what we call as a stent inside that. So there is a gap that we could create and let the gas and the contents come out, but that's only a temporary option. A colostomy is something that most of you must have heard. It could be a temporary one, it could be a permanent one, depending on the location, depending on the plan. Sometimes we do operate on the liver metastases or the lung metastases. And then also, I did not put it here, but there is an infusion pump that can be placed into the liver to specifically deliver chemotherapy only to the liver areas that are involved with the tumor. This is again reinforcing the same slide as the surgery. The orange parts are basically the nomenclature, what part is removed, what part is left inside, depending on the location. Chemotherapy or targeted therapy or immunotherapy. And you could get this therapy before or after, depending on the stage. The medical oncologist will determine this person will benefit if I give chemotherapy before the surgery, then send them to surgery, and maybe afterwards also. So if you give chemotherapy before surgery, we call it as neoadjuvant. If you do it afterwards, we call it as adjuvant. But it can be done before or after or both. And radiation is another. So, not all treatments are essentially foolproof, meaning they all can have some side effects related to why you're getting the therapy. Fatigue is one common one, hair loss, skin changes, nausea, vomiting, bladder issues. Patients can have diarrhea, depending on what portion of your colon is removed, and loss of appetite, because the chemotherapy essentially affects any rapidly dividing cells inside your body. So gastrointestinal cells are one amongst them. So you can have appetite issues or difficulty in eating, neuropathy, and trouble remembering and concentrating. All of these are during therapy type of side effects. Now, say a person is done with the treatment and they are essentially getting to the phase, a good phase. And now, what do I ask my provider? Do I need to eat some special diet after treatment? Are there any limitations on my activities? Can I go to work? Can I do the same things that I have done in the past? What other symptoms should I be watching for? So once you are diagnosed with cancer, understandably, our brain becomes very vigilant, essentially trying to watch for any signs or symptoms that your body is trying to tell you. What are the things that you should be watchful about and not get scared about every little thing that can happen? What kind of exercises I could do, what type of follow-up, how often do I come back, or do I need blood tests, do I need CT scans? And the next $1 million question is, do I need a repeat colonoscopy? And if yes, how soon? And how will we know if the cancer has come back? So essentially what we do is we have that's where your survivorship clinic at the cancer center comes into play, and they do talk to the patients about all of these things, and it's a beautiful center. The advice that they give is phenomenal. They have a dietitian, they have a genetic counselor. As I said, they do have a de-addiction area that talks about smoking cessation, alcohol, and all that. And they do refer patients to us when it's time for them to come back to get a repeat colonoscopy. Like, say, the guidelines tell us that 1 year after your diagnosis, you will get a colonoscopy. You have to get a colonoscopy. Again, the idea is that the cancer is gone, but you are now considered a high risk that the remaining portion of the colon can develop additional precancerous lesions or polyps, which need to be taken care of. And that's why you need a repeat colonoscopy. And you will be getting blood tests, you will be getting CT scans periodically, initially a little more often. And then as things are stable, they space them out. And then after a few years, your oncologist will say, listen, you don't need to come back to my clinic. You just can go to the survivorship clinic. That's a good thing.
Yeah,
that's yeah.
Oncologists love to say goodbye to their patients that way.
I know, it's a good sign. It's a very good sign. Yes. Mm-hmm. All right. So now, what are our long-term goals of treatment? As we just talked about, surveillance for recurrence, meaning you have to keep an eye on the patient and make sure that cancer did not come back. And then adherence to other preventive care guidelines, which means, if you need a vaccination for some other condition, if you need a pap smear, if you need a mammogram, make sure that you are actually adhering to those guidelines and not develop anything else that you do not want to. And management of late and long-term toxicities, and then again, healthy diet and lifestyle. So how do we check for recurrence, which we briefly touched upon? Blood test, colonoscopy, periodic CT scans. And these are the late long-term toxicities that we talk about. So that the treatment is done, patient is cancer-free, but they can actually have certain consequences that potentially could be long-term lifetime. Radiation damage is one amongst them. And the interesting part with radiation is it may not affect you at that time, but it can start, doing what it is doing 5 years later, 10 years later even. Sorry, 1 second. Patients can also develop diarrhea because they have had a portion of their large intestine removed. And as we talked about, the job of your large intestine is water absorption. And when you do not have the entire large intestine, there is a possibility of change in the bowel, how your bowels are working. And then ostomy care, where somebody had like a permanent ostomy, colostomy, then that becomes something that they have to take care of it lifelong. And then the last one is, we call it as diversion colitis. Again, people who have those ostomies, the leftover colon can also get inflamed. So, after you're done, you got everything taken care of, and then now how do you make sure that you don't develop another one in future? Again, getting to and staying at a healthy weight, eating healthy, regular exercise, vitamin D and calcium, your dietary supplements. Really, we do not know at this point which ones have been proven to prevent recurrence, quitting alcohol and smoking. And again, this is also, we touched upon the mammogram, the vaccination, screen for other preventable cancers, and emotional support, your social support, your family support. All of these are extremely important in sexuality and feeling good about your body. Again, I have seen flyers from the cancer center for you to be able to sit down, talk to them about all those. So we now dealt with this one person who came to my office. We took care of him. He's all good. We brought him to a point where the cancer is gone, and we keep an eye on him. But that's not how you want to deal with it. We need more good news. As Dr. Jagir was mentioning, the new good news is with colon cancer, it can be preventable, it is treatable, and it's beatable. The prevention part is where the role of a gastroenterologist comes in. In March is our National Colorectal Cancer Awareness Month, and nationwide there are several programs that are happening in terms of 5Ks or events, and I am planning on putting one together this year. We'll make some announcements once I have some concrete confirmations from them. And so what's the population that we cater to prevent colon cancer? So first you have to know your risk. Do you have at least one family member with colon cancer or precancerous polyps? Have you experienced bleeding or blood in your stool? Do you have a personal history of precancerous polyps on a prior colonoscopy? You will be surprised if I tell you patients have had a colonoscopy 10 years ago, they have had precancerous polyps. And a lot of times the information you'll get is, yeah, those polyps are benign. Precancerous polyps by definition are benign. But again, the information that you need to be aware is, what is the pathology of the polyp? In the medical jargon, it's called as adenomatous polyp. When you see the word adenoma, tubular adenoma or adenoma, that means that is a precancerous polyp. Once you have had that polyp, you are considered a high risk for developing polyps again. So you cannot wait 10 years to get a repeat colonoscopy once you have had a precancerous polyp. Now, have you ever had a positive take-home stool test? Have you been diagnosed with inflammatory bowel disease in the past? And this was the condition that we talked a little in the past, the ulcerative colitis and Crohn's disease. If someone has the diagnosis, they are considered high risk. So we risk stratify these people. Average risk is no signs or symptoms, no family history. That's your technically average risk or low risk population. And anybody else is considered higher risk. If you have a personal history, if you have a family history, inflammatory bowel disease, or these genetic syndromes, which put you at a highest risk. This is also a busy slide. Your family history certainly matters. And when you come to a specialist, we will ask you as to how many, if you say yes to family history, then we ask you who in the family was diagnosed. Your first degree relatives definitely put you at a much higher risk than a second degree or a third degree relative with colon cancer. And sometimes there are a conglomerate of different cancers, like say, a 35-year-old woman comes to my office and tells me, listen, my father was diagnosed with colon cancer in his 50s, and my dad's mother, my paternal grandmother, was diagnosed with ovarian cancer when she was in her 70s. And then my paternal uncle's daughter, who is my cousin, was diagnosed with uterine cancer in her 40s. So now that should ring a bell in my brain where, okay, this family history now has 3 different family members. Everybody's related to each other. One of them a little younger, one of them in their 60s, a little younger in the sense less than 50 is that, again, that number I have to keep in my mind. So I have to think that this person is considered high risk for developing colon cancer just based upon her family history. So when we take a family history, when we ask for family history, it is extremely important for us to know what are the particular ages of diagnosis, not when they passed away, if that happened. It's mostly the decade that they were diagnosed, at least roughly 50s, 60s, and that puts the people in the appropriate bracket of risk. Now, when do we start screening? Up until very recently, the average risk individual was getting screened at 50, all right? But then now, last few years, every society, the Preventive Services Task Force, AC, American Cancer Society, was the first one to actually advocate for age 45, and other societies picked it up a year or two later. But now we do start screening at 45. So 45 is the new 50. And when someone is considered high risk, which means the individuals that we talked about, you start screening at age 40 or 10 years younger than the youngest family member. Say if the father was diagnosed at 45, now you start screening the children at 35. That's still less than 40, but you have to pick an age, either 40 or 10 years younger, whichever is the earliest. And then the third category is your inflammatory bowel disease, your ulcerative colitis patients, where if they have had it throughout the colon, we start 8 years after the diagnosis and you repeat it every 1 to 2 years. The cancer syndromes also, we start screening them in their 20s. And with the cancer syndrome patients, it's even unique. As I said, they could be very unrelated completely, as we talked about. It could be in the uterus, it could be in the ovary, it could be in the stomach, it could be in the pancreas. So you have to, again, think of this as a whole and then start screening them for all of those cancers. So that's where our role comes in as to what referrals do we send them to, what imaging studies do we send them to, what other cancers in this particular syndrome I could prevent. So that's a completely different set of population. So this is a relatively a busy slide, but there are several options when you talk to your primary care or talk to a gastroenterologist as to what options do I have for screening. Some of them are visual exams. Some of them are indirect stool-based tests. The stool-based tests are your either guaiac-based, we call it as fecal occult blood test, which is checking. So hemoglobin is what we are testing for. The word hemoglobin has two different components. Heme, which is your iron containing product, and the globin, which is your protein part. You can really, technology has advanced so much that you can test for the heme component with one test and then the globin component with another test. For many, many decades, we were only testing for the heme component, which is through your fecal occult blood test. But then the problem with that was any other molecule in the body that has the heme or any other dietary components that has that molecule was actually giving us false positive rates. So it was not such a great test to essentially identify, but still, something is better than nothing. We have relied on it for a long time. And then came in the relatively newer test. It's called as fecal immunochemical test. And what this is it actually detects the globin component of the hemoglobin. And why is it important is it's a protein part, and if there is blood coming anywhere from your upper GI tract, your stomach or small intestine, by the time it comes to the exit, meaning by the time it comes into the stool, the protein is degraded. Whereas if it is truly coming, if the blood is coming from your large intestine, it cannot be broken down and it is detected. So the numbers are better in terms of ability to detect and the suspicion. Again, another test that you may have heard or watched it on a TV commercial is your Cologuard, or it's a multi-targeted stool DNA test. And Lauren is going to provide a link in the chat window or on the website. It's a cute little video as to, I wouldn't say cute, but a little video as to the instructions, how to do it. So what Cologuard is, it's a combination of two different tests. The immunochemical test that I talked about, which looks at the protein part of from the blood, and also includes a DNA that is being shed by the polyps or the cancer. And the reason this has been, it has got 2 steps, which detects, I think we would think that it would detect at multiple levels. The caveat with this is the company is not going to tell me which one is positive amongst the 2, whether the DNA part is positive or the globin part is positive. It will just tell me stool test is positive. So what do we do when we hear that the test comes back positive? Any of the stool tests for that matter. You have to go down with a colonoscopy to confirm that there are no polyps or cancer, or, you know, if there are polyps, you take care of them. If there is cancer, you take them. So it is an at-home test, no anesthesia, no preparation needed. You do it at home, and it has to be repeated every 3 years. And this has become somewhat of a popular test, but the idea is that this is not applicable for the high-risk population as it is, meaning if you have had polyps in the past, if you had family history, this is not an ideal test for you to go through. You still have to go through a colonoscopy. The insurance companies, interestingly, up until last year, were not covering a colonoscopy following a positive Cologuard as a preventive test. They basically said, oh, we covered one screening test, you came back positive, you're on your own to get the colonoscopy. Now, Medicare, CMS has changed that. They do cover it much recently in the last 6 months to 1 year. They do cover that as a screening colon fully. Now, there could be false positives, there could be false negatives. And when we say false positives, meaning the test did come back positive, but the patient did not have anything. It has raised a false alarm in that patient's mind, and they were anxious. So we tried to get them in as soon as possible to get the colonoscopy done and take care of it. So that's about a little more than 10%, actually 13% to be specific, the false positive rate. And the false positive rates are also somewhat higher if you're older. So more than 65 age group, the false positive rates are somewhat higher. And the false negative rates, meaning like you had a test negative and you went to bed very relaxed, but there is about an 8% of false negative rates, which means out of the 100 negative tests, 8 of them could be wrong. So we just have to remember these indices with certain of these indirect testings. Now,
So in summary, the colonoscopy is the gold standard.
Colonoscopy is still the gold standard because it gives you a direct exam of the entire colon and rectum. And if you see something, do something about it. It's a one-stop shop where if you see the polyps, you take them out, you send it to pathology, and the job is done. And if you have nothing in the colon, then you're good for 10 years, and it doesn't have to be repeated every 3 years.
But if you don't want to do a colonoscopy, we just ask you do something. We'll take the test you're willing to do.
Yeah, if someone declines it, yes, exactly. The other,
a little short on time, so we can talk about the young folks too.
Yes, I'll move on faster then. Okay. The other visual examination tests are a flexible sigmoidoscopy and a virtual colonoscopy, which are done again also it's a visual testing, but it's a CT-based testing. So these are pictures of how things are done. And the other thing that I haven't mentioned in the other slide is a pill cam, where a colon capsule, it's a tier 3. It's not as popular. It's got cameras on both sides where you swallow the capsule, you prep yourself, you clean, and it takes pictures. And the pictures that are analyzed and looked for polyps. Again, this is the slide where we talked about it, the advantages of colonoscopy. Again, one-stop shop. We looked at it. We take care of it at the same time. Again, you need a caregiver. We need to have someone come with you for transportation. You have to take a day off from work. And there are some sedation risks and perforation risks exist. But again, overall, it's a very safe procedure. We do these all the time. The complication risks are significantly low. You're talking about 1 in 1,000 to 1 in 3,000. For an average risk, a 45-year-old, this is something that is, you got to get this done to make sure that you don't run into trouble in future. And then the stool-based test we talked about, they're cheaper, they're easily available. You could do it at home. You're not missing any work, no anesthesia involved, non-invasive. But again, it's not a test. Please remember this. This is not a test. If you have a personal history of polyps in the past, personal history of cancer in the past, if you have any family history, this is not the test that's right for you. You have to go for a colonoscopy. And this is something, it's not a one-time test. You have to be repeating this at regular intervals if you chose this route. If it's FIT, it's every year. If it's Cologuard, it's every 3 years. This is the Cologuard link that Laura will make
And
it
we'll
available for
also
you.
put this link up at the website as well.
Yeah, okay.
So we're
And-
gonna have to move from polyps to the young ones, and then we'll, yeah, we don't have enough time for
All
GIG.
of that. Oh, okay. Okay, all right. These are pictures of polyps that we see, and this is a newer tool that we have. It's called GI Genius. It's AI provided algorithms where it helps us detect polyps in a better way, and the company claims about 8 to 14%. And I think most of us recognize who this gentleman here is. This is the young onset colorectal cancer, by definition, less than 50 years of age, and that's Chadwick Boseman or South Carolina. Now, since 1994, NCI has reported a 50% increase in the young onset colorectal cancer, and we talked about this. The revised guidelines now say that you start screening at 45 and not at 50. And it's pathologically, it's very similar to the regular older adult cancer, meaning the pathology-wise it's the same, but they're more left-sided cancers, and we do not know why this is happening, but we think these are the factors that play a role: diet, inflammation, lack of physical activity, genetic alterations, and gut bacteria. And the two major issues in this particular age group is identifying the cancer, as we talked about, because they tend to ignore the symptoms for longer periods than somebody who's older, and their unique challenges, which include social, emotional, and fertility issues, sexual health, mental health. And so there are special centers at various cancer institutions that offer support in all of these areas. And now I think we're coming to an end. How do we lower the risk of colon cancer? Again, eat healthy. The Cancer Society recommends about 5 servings of fruit and vegetables each day, foods rich in calcium, folic acid, like your legumes and broccoli. Exercise regularly, even if it's like a moderate physical activity, like, park farther away or take the stairs instead of an elevator. Simple exercises, everything is important. And again, obesity is a major risk factor. And again, this is a very, I wouldn't say controversial, but we don't know much about the effect of the gut microbiome on colon polyps. I'm sure all of you heard about this. It's very, I wouldn't say popular, but very commonly discussed topic. We all have trillions of bacteria that are inside our colon, and they all have wide and significant influences on the metabolic functions of body. They can be good or bad bacteria that I tell my patients, and they are very different, meaning you and your wife have very different compositions of these bacteria, and they are all based upon your gender, your genetics, your diet, your physical activity, prior disease, drugs, environmental toxins, all contribute to which bacteria is predominant and what proportion. And it's an extremely complex. I don't know if in my lifetime there will be a test where they can get a stool sample and then map all of these bacteria for me and tell me, what diseases I'm prone to. That's the idea, I think.
You're young, it's going very quickly.
It's going very quickly. Okay, we'll see. And
Well, listen,
again,
I'm gonna, that was a whirlwind of everything we want to know about colon and afraid to ask. And one of the things about the young onset colorectal cancer, I mean, this is in the adolescent young adult population, and they have their own issues from the standpoint they're just starting out. They're starting, with families. They may be uninsured, underinsured. If you have a family member or an associate that's having some GI symptoms that might require a colonoscopy, you could find ways that could get paid for, right? I mean, if we don't
yes.
want to deny them any kind of care.
No, absolutely not. Absolutely not. They could get sponsorships, and there are networks and foundations, coalitions nationwide that can actually offer them a free colonoscopy through a set of gastroenterologists. In fact, we are part of the colon cancer prevention network that works out of Columbia, and funds that are raised through any of the awareness campaigns stay local and within the state of South Carolina, I meant, and they do offer procedures for free.
Yeah, so there should be no barrier to you're getting the right kind of healthcare, and that's true. I mean, we are well served in the upstate with not only Prisma but St. Francis and Spartanburg Regional and Gibbs Cancer. I mean, they all have gastroenterologists, they all have colorectal surgeons, surgical oncologists. And so they can give you this multidisciplinary care, and there shouldn't be any barriers for you getting the right kind of treatment if your symptoms dictate it. It's really important, and I think Dr. Jamala did a great job of emphasizing that there are modifiable risk factors for this disease. And so somebody who potentially has it in their family, there's some things you can do from the standpoint of weight and diet and exercise and social connections, getting plenty of sleep, and maybe some probiotics that could help decrease your risk over time. One of the things that Dr. Jamala mentioned was that March is going to be Colorectal Cancer Awareness Month, and you're familiar with those ribbons, and there's a ribbon color, and it's a very pretty royal blue, and I'm aware that it's a royal blue because now the Cancer Survivors Park has the Beacon of Hope, and we have 9 lights that are lighting up the Beacon of Hope. And this month it's a pretty green color for gallbladder and bile duct cancer. But starting March 1st, that Beacon of Hope will be lit up in a royal blue that will be available to see from a lot of parts of Greenville. So if you have a colon cancer story, please make a journey to see that. But it'll be up in March. Our next session will be Hope, Help, and Hospitality. The upstate support organizations will be available. We do have the Upstate Cancer Network, and we'll try to emphasize what they do, their own special capabilities within our support organizations. So I normally end with a couple of quotes, and we're going to quote a couple of U.S. presidents here, and I think it's got some appropriateness to the subject that we've been discussing. And this is from JFK: "The time to repair the roof is when the sun is shining." And from President Truman: "There is some risk involved in action. There always is. But there is far more risk in failure to act." So we'll call that a night. And Dr. Jamala, thanks so much for your energy in presenting and all this really good information. And hope everybody has a good rest of their evening and the rest of their month of February. Remember, we got 29 days this month. So I saw nothing in the chat for questions. So we'll say good night.
Thank you, Dr. Jagir. Thank you for everybody being here. If you have any questions, I work in the main Prisma area on Paris Road, and I'm sure Laura can get you in touch with us. We'll be happy to take care of any issues or any of your family members. Great. Thank you again. Have a good evening.
Bye.